What's up, Doc Mike? Public Health on Call. By Johns Hopkins Bloomberg School of Public Health. Today's topic for December 17, 2020. The impact of racism on child and adolescent health. Thank you, Johns Hopkins Bloomberg School of Public Health.
Welcome to Public Health on Call, a new podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Josh Sharfstein, a faculty member at Johns Hopkins and also a former health commissioner in Baltimore City. Until recently, our sole focus has been COVID-19 and the global pandemic. We are broadening the podcast now to other urgent public health issues. This episode is being broadcast on Juneteenth, a day commemorating the end of slavery in the United States, on June 19, 1865, when Union soldiers finally reached Galveston, Texas. I speak with Dr. Maria Trent, a professor of pediatrics at Johns Hopkins and the chief of the Division of Adolescent and Young Adult Medicine at the Johns Hopkins School of Medicine. Dr. Trent is the lead author of a landmark statement from the American Academy of Pediatrics that was published last summer, entitled The Impact of Racism on Child and Adolescent Health. We speak about this urgent topic and what pediatricians and others who care about children can do about it. Let's listen. Dr. Trent, thank you very much for joining me on this podcast. I'm really wanting to talk to you about this landmark position statement that the American Academy of Pediatrics took called The Impact of Racism on Child and Adolescent Health. It came out last summer, and you were the lead author. How did this statement come about?
So the AAP policy statement, first of all, thank you for having me. But the AAP policy statement was really in progress for over 2 years before it was produced last summer. It just so happened to really coincide with the events that were happening in El Paso, which I think was timing that was essential because I think it allowed for us to really talk about discrimination in a thoughtful way. But I think we were concerned initially about the discussions that were taking place in the public space after actually the Freddie Gray unrest here, and that resulted after Freddie Gray's death here in Baltimore. And so it really was counter what people were saying, sort of on television, to parents, to the public, were really things that were counter to our training as pediatric health professionals.
What do you mean? What were they saying?
There was this one incident where a mother went looking for her son and she found him. And it was a really almost altercation. You could see her fear. I'm not saying this in judgment, but I think the notion in sort of popular media, on Oprah, on Fox News, it really varied significantly. The notion was that this is how we engage our children when they do things that we don't agree with. And I think I was conflicted about it, in part because that patient, that person, that young person, and that mother, they could have been our patients here at Hopkins. They're not, as far as I know. But I really felt the sense of how would I speak with her about what happened in the office. How would I lend support to them as a family? Because in subsequent interviews, she really talked about the fear that she experienced and that he was her son and she had to do something to stop what was happening to get him out of there.
And she was hitting him, is that right?
She was hitting him. There was some cursing. So it's just you could sense the emotion that she felt about it.
But she was trying to keep him safe. That was the idea.
That is correct. And so the question becomes, how would we have spoken with that family? And I think at the time we were a part of the DC Baltimore Research Center on Child Health Disparities. And we were a site here at Hopkins, and we really collaborated with a team. So we actually created a team that included Renee Jenkins, who's the former president of the AAP, as well as the former president of SAM. We also work with Janie Ward, who is an educator on the faculty at Simmons College, who really has written books about raising resistors and how do you do that, particularly for African-American families. And Michael Lindsay, who is a PhD social worker he was at the University of Maryland, but it's now on the faculty at NYU. And the four of us really went on the road and we talked to our colleagues at the American Academy of Pediatrics or the Pediatric Academic Societies meeting. We talked to people at the National Medical Association meeting. And the thought was really that we needed to provide guidance to pediatricians about how to do this in the office.
Sort of a new language of talking about racism with families.
A new language, but that would be integrated into our existing products like Bright Futures, which is sort of an AAP product. And really had a lot of support from the past presidents of the American Academy of Pediatrics who really said this is where it needs to be. But the folks in Bright Futures says, we can't do this, but what we need is a policy statement. So it's not AAP policy that we are talking about racism this way, and we need the organizational's agreement and statement that this is the direction we want to move in.
So the statement itself, so that brings you to the statement. Now you've got to actually put it down on paper.
That's correct.
And it starts by noting that race is not based in biology. So could you explain a little bit when you're, trying to give people a language about racism, how you explain race?
Right. So just to clarify, so the things that we see, the differences that we see, they are biologically based, but they really represent a small fragment of our genetic code, right? There's really only one human race. Like we're pretty much 99% the same. And we just spend so much time trying to decode that 0.1% difference, or at least use it to explain race sometimes. But other times, I think it's most appropriate in the way that we're using it. But I think we spend a lot of time focused on the things that make us different and not necessarily the things that we have in common. And I think we have to understand that the health disparities that really are observed in certain racial ethnic groups, like African-American populations, Native American populations, and Latinos, really emerged because of their link to these unchecked forms of discrimination over generations. And really intergenerational trauma is really contributing to people's health status. I think the other thing you really see is you can see how trivial the race becomes when you look at how we've categorized people from a public health perspective, or how the government categorizes people over time. That has changed substantially since the beginnings of the United States. I think certainly African Americans have always sort of been in a Black category or a Negro name category. But I think there's been significant changes which suggest that if it was biologic, it would not be changing. There are most of the things that we see happening or have its roots sort of in some of the work that was done in Europe. Earliest as the Spanish Inquisition is where you really see this rising. And the thought is that some of those thought processes were really carried to the New World or the United States as we begin to explore and populate other regions of the world.
So the concept of race, the way people use race, isn't because of the biology. It's because of all of this other meaning that gets brought in and leads to this, very disparate treatment and all these consequences.
It is a social construct, yes. So we began to categorize people into groups based on what we see. And because of that, we've attached value to it. And because we attach value to it, it becomes a social construct that dictates what one has access to, what spaces people can occupy, and ultimately their health status.
So speaking of health status, the statement points out that there are many different efforts that have tried over the years to address gaps in health by race. And yet major gaps for minority children remain. And it calls out racism as one of the major reasons for these persistent gaps. Can you explain a little bit about how you got to that point, maybe with some examples?
Sure. So I'll just go back to the point about this intergenerational trauma just so it's clear that, physiology of trauma is a very interesting one, where you have people have an event, they have a heightened response. They have another event, but they recover. And then they have another event, and they probably will recover from that event as well. But over time, when an individual or a population of people continue to have those same insults, over time, their physiological response to those repeated stressors changes so that they can survive. And individuals really begin to shift. They develop, and as a result, oftentimes they may develop inflammatory disorders or cardiovascular disease, like hypertension, and then those things can be passed on through generations. I think what we see in as it relates to children is that there are a series of threats that affect health status that begin in utero. As an example, African American mothers are predisposed to have complications of pregnancy that appear to supersede both economic and one's sort of station in life. And they're otherwise really unexplained in the public health literature. And I think that it's probably due to a combination of factors. Former director of the Maternal Child Health Bureau, Michael Liu, really has described in his work on health disparities and the reproductive health potential of women, how these threats sort of bear down on their biology from the beginning and from birth, and that some of those issues include racism, economic deprivation, stress, but also increased burden of disease. And so you can see that playing itself out in African American women over time, and then in their pregnancies, and then the children they produce. I think that there are other things that we think about as pediatricians. We think a lot about developmental outcomes in children. Developmental outcomes may range from access to early literacy programs, which we're trying to address through our work in the AAPI with Reach Out and Read, or access to early education or to the quality of education. Those things are really fall along our tax base. We see them increasingly segregated in the United States. We see them, the schools by race, even in some of the wealthiest counties here in Maryland, really do see differences in educational outcomes, access to gifted programs, and those things really do play out over time.
So it starts with, from in utero, there's the impact of racism. And then as children grow up and they're basically discriminated against in their educational opportunities, that magnifies the problem.
That's correct. And then they may also have events, things that happen to them that further accentuates their experience of racism. And I say accentuate, but certainly in a negative way.
And that could, for example, involve interactions with the police.
It could involve interactions with the police, but it could be interactions with teachers. It could be where they're placed, how people see their value. I think people have to be able to see them and to offer them opportunities. It's interesting, the Johns Hopkins School of Education has done this work, and they really have demonstrated that there are tons of gifted children in Baltimore, as an example, and that talent is everywhere, but the opportunity is not. And it's something you hear people say a lot, but they really provided the data to back that up. And there's also data that suggested if we re-examine our approach to gifted education, that we could actually close the gaps in educational disparities, which for me are developmental outcomes in children and adolescents and young adults that exist now.
The statement really pulls pediatricians a little bit away from the exam room to thinking about the educational system and some other key systems that impact the effect of racism on children. Mm-hmm. Are there others beside the educational system you would put in at the, kind of in the like urgent, warning light, kind of glaring pile?
Sure. So, well, I think that we do ask them to step outside of themselves in the policy statement. I think we do ask them to stay in the office for a minute first.
Okay, tell me about that. So what do you want pediatricians to do in the office? What's that language that you're giving them in this statement?
The first thing that we're asking pediatricians to do, and this is like ground zero, really, is to examine where they are, to look at how they're interacting with children and patients and families to make sure that they're able to create that space in which bias does not enter. Surprisingly, there's significant data that's available that really demonstrates that even in context of pediatric care, there's evidence of explicit and implicit biases that affect patient care and the outcomes that people have. So we have to do some self-examination first. I think that's the thing that was really important to this statement for the American Academy of Pediatrics to really say, while we're going to step into some of these other zones, the first thing we're going to do is we're going to get ourselves together. And I think that's an important piece, I think, of the document. The other thing is then we have to set up our practices, our institutions, to really critically examine how we're delivering care. What is the office set up like? If we're in a place like Baltimore that has an emerging Latino population and we have no one who speaks Spanish at the front desk, that's an issue. If we're not set up to show, if we have an office where we have images up on the wall and we never have images of patients who live in the community or who are served by that space, it doesn't necessarily say you are welcome here. Or if we give out, there's a lot of data on the impact of early literacy programs on child health outcomes. If we never give any of those patients books written by someone who looks like them or someone who's different from them or just different, we really limit the kinds of stories that children begin to understand and begin to see. We impact their imagination from a very early age. So I think the small things that we're doing in the office, they may seem like small things, but I think they're really important in terms of shaping what practice looks like. I think we have to train our staff. There are a lot of people who may be poo-poo the value of, if that's an official term, of cultural competency training.
In pediatrics, that's an official term.
Yes, in cultural competency training. But the reality is that, even here we've demonstrated just by spending 3 hours with residents and fellows and allowing them the opportunity to do simulated training in cultural competency in the same way we would train them in CPR or any other procedure that they're learning here to invest that time. We actually see them change in 3 hours. We see them learn how to use interpreters differently. We see them navigating spaces with parents on complex cultural issues. With
people who are skeptical.
And their self-efficacy improves. They say, this was the best cultural competency training that I've ever been to. And so we have to figure out how to operationalize that in pediatrics so that I think we're doing our best before we step out into those other spaces. But what I will say is that, pediatricians are serving in a lot of different spaces. Some of them are working in school-based health centers. Some of them are working in the juvenile justice systems. And I think we have an opportunity to impact those other places where young people may be disproportionately impacted. And so I think that for pediatricians to step out into some of those spaces is certainly reasonable. We have people who work at the FDA who are pediatricians. And so they have an opportunity to impact policy around how children access medication and things that might be harmful to them. And so this is an opportunity for pediatricians to really identify the places in which they can have impact. Right now, because children spend so much of their time, people can debate how much of the day it is. Should we count whether or not it includes when they're sleeping? But of their waking hours, a good portion of that time that they spend during the day, during the academic year, is in school. And so that's got to be a place where we have to have some realistic dialogue about what's happening to them and to create experiences that reflect the diversity of the populations that we're seeing. Even when the populations are diverse, we have to really reflect this era of diversity and inclusiveness. And so I think that's something that we can also work with schools on around those issues.
So I just want to maybe end where you started, which is, there are these difficult conversations to be had. How do you think that pediatricians who are following this set of recommendations, which includes this training and a whole bunch of other steps, are going to be better able to handle the difficult situations like the mother in Baltimore, or parents who are frankly very worried about the safety of their children and other difficult issues that come up?
So, it's interesting. I have found really that it's not actually so much what people say, although what they say is important, is that they also create a space where they can listen to people. And I think at this stage, listening is a critical piece for us to really understand and enter those spaces where we may be uncomfortable. I think that if we're not used to hearing about individual trauma or family trauma and about this particular topic, then we say that we can't do it. It's interesting because I was talking with a group of communicators at Hopkins last week, and they are teaching the next generation of physicians about this notion of patient-centeredness, patient-centered care, family-centered care. But they were stuck on this particular issue. And I couldn't figure out, why is this issue any different? How could this be harder than telling someone that they have an awful diagnosis, or that they were going to need some surgery that they didn't anticipate? Why would we not approach this particular issue with the same care and respect and compassion? Empathy is at its core. So I think that people are more skilled than they think, but I think they do need to go through processes to incorporate these topics into those skill sets. I think pediatricians are notoriously kind and thoughtful and caring of the patients and families, but I think they just need a toolkit around this particular topic to enhance their skill set.
Great. Well, thank you very much for your work on this statement, but all of your work in this area, and really appreciate your joining me.
Thank you for having me.
Thank you for listening to Public Health on Call, a new podcast from the Johns Hopkins Bloomberg School of Public Health. Please send questions to be covered in future podcasts to publichealthquestion@jhu.edu. This podcast is produced by Josh Sharfstein, Lindsay Smith-Rogers, and Lamare Morales. Audio production by Niall Owen McCusker and Spencer Greer, with support from Chip Hickey. Distribution by Nick Moran. Thank you for listening.